You can eat a balanced diet, take your vitamins, pass your annual physical, and feel completely fine, while your body has been printing a warning on your tongue for months that nobody ever told you to look for. Stick out your tongue right now, not to say ah for a doctor who has 30 seconds for you. Actually look at it. The color, the texture, the edges, the coating. What you are about to see, if you know what to look for, is a direct readout of what is happening in your blood, your gut lining, your immune system, and your nervous system at this exact moment. What I am going to walk you through in the next several minutes has been standard knowledge in clinical medicine for over a century. It is documented in textbooks, it is taught in medical schools, it was used as a primary diagnostic tool before blood tests and imaging existed, and yet somehow, the conversation about what your tongue reveals about your internal health never makes it into the 20-minute office visit. It gets filed under interesting but low priority. The labs come back, the blood pressure cuff comes off, and the one organ that is sitting right there in plain sight, for free, with no needles and no machines, gets glanced at for 2 seconds and ignored. 6 signs, 6 internal warnings. And after 55, the stakes on each one are significantly higher than they were at 35, for reasons I am going to explain precisely. At the end of this, I will walk you through the 3-surface read, a 30-second morning check that maps 3 distinct zones of your tongue to 3 internal systems that are chronically under-monitored in this age group. I will give you the exact sequence, what to look for in each zone, and the one mistake that makes the entire protocol useless if you skip it. But before we count down, there is one invisible biological process that connects almost everything on this list. I need you to understand it first, because once you do, every sign that follows snaps into focus. Your tongue is the only internal organ in your body that is directly visible from the outside without any imaging, any blood draw, or any procedure. Every other organ hides behind skin and bone and fascia. Your tongue sits in your mouth and keeps printing. Think of it like the receipt printer behind the counter at a restaurant. You cannot see the kitchen, you cannot see the inventory system or the order management software. But every transaction that happens back there eventually shows up on that strip of paper at the front. Your tongue is the printout. It never edits, it never softens the message, it just keeps printing whether you are reading it or not. The invisible villain in this story is a protein called intrinsic factor. It is produced by specialized cells in the lining of your stomach called parietal cells. Its job is specific and non-negotiable. It binds to vitamin B12 in the digestive tract and escorts it through the wall of the small intestine into your bloodstream. Without this protein, B12 cannot be absorbed, regardless of how much you consume. Here is what changes after 55. The stomach lining naturally begins to thin as part of the aging process. The parietal cells that produce intrinsic factor become less numerous and less active. Simultaneously, stomach acid production, which plays a separate but related role by chemically freeing B12 from the protein structures in food so it can bind with intrinsic factor, also declines. The combination means that your B12 absorption capacity can drop significantly, quietly, with no acute symptoms in the early stages. Nothing hurts. Nothing announces itself. The American Journal of Clinical Nutrition has documented that up to 30% of adults over 50 have measurable reduction in B12 absorption due to declining stomach acid and intrinsic factor output. And the current dietary reference intakes for B12 were established using absorption data collected in younger adults. The number was never corrected for the aging gut. Now add 2 more layers that compound the problem. The first is Helicobacter pylori, the bacterial infection that lives in the stomach lining and is estimated to be present in approximately 30 to 40% of adults in developed countries, with prevalence rising with age. H. pylori directly damages the parietal cells that produce intrinsic factor. Many people who have it do not know. They have vague digestive discomfort that they attribute to stress or food sensitivity or simply getting older. In the background, their intrinsic factor output is being eroded. The second layer is metformin, the most commonly prescribed medication for type 2 diabetes in the world. Research published in the British Medical Journal found that long-term metformin use is associated with significantly increased risk of B12 deficiency, with one large analysis finding that approximately 22% of long-term metformin users had deficient B12 levels. The mechanism involves metformin interfering with calcium-dependent membrane uptake of the intrinsic factor B12 complex in the ileum. Most patients taking metformin are never told this. The drug's prescribing information mentions it, but the conversation rarely happens in practice. You could be eating red meat regularly, you could be taking a standard multivitamin, you could have a clean bill of health from your last physical. And if your intrinsic factor production is low, or your H. pylori infection is quietly active, or you have been on metformin for years, you could still be running a functional B12 deficit that is slowly and silently degrading your nerve insulation and your cognitive architecture. Your tongue will show this before a standard blood panel catches it. That is sign number one, and I am saving it for last because the mechanism is the most important thing in this entire script, but we need to build toward it. Sign number six. You notice irregular patches on your tongue, smooth reddish or pinkish areas with slightly raised white or yellowish borders, surrounded by otherwise normal-looking tissue. The patches seem to shift their location. They are in one place one week and somewhere slightly different the next. Sometimes they disappear entirely, which makes you think the problem has resolved. Then they return. This is called geographic tongue, or in clinical language, benign migratory glossitis. The name comes from the fact that the patches resemble continents on a map and they migrate. Most people who look this up are told it is harmless and has no treatment, and technically that is not wrong. Geographic tongue is classified as benign and in the majority of cases does not require medical intervention. But the classification of benign describes the lesion, not the signal behind it. Geographic tongue represents a localized loss of the small projections called papillae that normally cover the tongue's surface. Those projections have extremely high cellular turnover. They regenerate constantly on a cycle of just days, and they are rich in metabolic activity. When the body is running low on certain micronutrients, particularly zinc, folic acid, vitamin B6, and other B-complex vitamins, the papillae are among the first structures to show the shortfall. They atrophy, they flatten and disappear, leaving the smooth, exposed-looking patches. Think of it like turf dying in patches on a lawn. The grass with the shallowest root system and the highest metabolic demand goes first. The rest of the lawn looks fine temporarily, but the patchy areas are telling you that the soil underneath is depleted of something. The lawn is not sick randomly. The lawn is responding to a deficit in the substrate. A study published in the Journal of the American Academy of Dermatology found that individuals with geographic tongue showed significantly higher rates of atopic conditions, immune-mediated, inflammation-driven responses, compared to control groups. In adults over 50, geographic tongue has also been associated with psoriasis, which affects approximately 7.5 million Americans and shares a common inflammatory pathway involving interleukin-mediated signaling. What this means practically: geographic tongue is not something to treat, it is something to read. It is telling you that some system of cellular maintenance is operating below capacity. The responsible next step is not to ignore it because it does not hurt, but to ask which system that is and whether it has downstream effects beyond what you can see in the mirror. Sign number 5. Look at the left and right edges of your tongue, the lateral margins where the tongue surface meets the side. If you see a series of rounded indentations, scalloping, or wave-like impressions running along those edges, you are looking at what clinicians call a crenated or scalloped tongue. Those impressions are made by your teeth pressing into the tongue tissue over time. The instinctive assumption is that the tongue is simply too large for the mouth, and that is partially accurate. The tongue has expanded. But the clinically relevant question is why. The tongue is made of muscle and connective tissue. Like all soft tissue, it swells in response to inflammation, altered circulation, and fluid retention. When the body is holding excess fluid, a condition called edema, the tongue swells along with the face, the hands, and the lower extremities. It presses against the teeth leave their marks. The scalloping is essentially a pressure record. The tongue is functioning like a pressure gauge on a water line. The marks tell you the pressure inside the system has been elevated. Hypothyroidism, where the thyroid produces insufficient thyroid hormone, causes a specific type of soft tissue fluid retention called myxedema. It affects the tongue, the face, the hands, and the lower legs preferentially. And tongue enlargement with scalloped edges is a recognized clinical feature. The American Thyroid Association estimates that 1 in 8 women will develop a thyroid disorder during her lifetime, with the incidence rising sharply after 60. Many cases are subclinical. The TSH level is technically within range, but the patient is symptomatic, and subclinical hypothyroidism remains one of the most underdiagnosed and undertreated conditions in women over 55. But there is a second cause of scalloped tongue that is even more prevalent in this population and almost never discussed: obstructive sleep apnea. When breathing is repeatedly interrupted during sleep, blood oxygen levels drop. The body responds to this chronic nocturnal oxygen debt with systemic low-grade inflammatory signaling, which causes soft tissue swelling throughout the upper airway, including the tongue. The swollen tongue then mechanically worsens the apnea by contributing to airway obstruction. The cycle repeats through the night, every night, while the person wakes feeling moderately unrefreshed and attributes it to getting older or to stress. The American Academy of Sleep Medicine estimates that approximately 26% of adults between 30 and 70 have obstructive sleep apnea. The majority are undiagnosed. The tongue scalloping is visible every morning in the bathroom mirror. The connection is almost never made. There is a third angle here that compounds both of the above. Magnesium deficiency is estimated to affect between 60 and 70% of American adults, with absorption further declining with age. Magnesium is directly involved in regulating cellular fluid balance and inflammatory signaling. Suboptimal magnesium amplifies soft tissue edema and inflammatory tone, meaning it can make the tongue swell from a different mechanism, while thyroid dysfunction or apnea pushes from another direction simultaneously. Multiple underaddressed deficiencies layering on top of each other and producing a single visible sign. The tongue is printing the combined total. Sign number 4. You have probably noticed a white residue on your tongue at some point and assumed it was just morning dryness, or leftover food, or something that would brush off. And often it does. But a thick, textured, consistently returning white coating, one that is present every morning, particularly toward the back of the tongue, and that does not fully resolve after drinking water, is something different. The surface of a healthy tongue is colonized by a balanced community of microorganisms living in a thin, organized film: bacteria, fungi, and a handful of other players that sits over the papillae in a thin, nearly invisible layer. In a balanced state, this biofilm is translucent and does not affect the tongue's appearance significantly. When the balance shifts, when the fungal population in particular overtakes the bacterial populations that normally keep it in check, the film thickens, turns white, and becomes visible. The primary organism responsible is Candida albicans, a fungus that naturally inhabits the mouth and gut in small numbers in most adults. Under normal immune conditions, bacterial populations and immune defense mechanisms keep it contained. When immune surveillance weakens, when bacterial populations are depleted, most commonly through antibiotic use, or when the local environment becomes more favorable to fungal growth through elevated glucose availability in saliva or reduced saliva production overall, Candida seizes ground. It forms a visible white film called oral candidiasis, or thrush, and the tongue is often the first place it becomes apparent. After 55, the most common driver of this shift is not immune aging alone. It is medication-induced dry mouth, and the scale of this problem is genuinely underappreciated. More than 400 commonly prescribed medications list reduced salivary flow as a side effect, including antihypertensives, antihistamines, antidepressants, diuretics, anticholinergics, and proton pump inhibitors. The average American over 65 takes 4 to 5 prescription medications. When you stack the dry mouth side effects of 2 or 3 of those simultaneously, you have dramatically reduced the one natural defense mechanism that physically washes oral fungal populations off the tongue surface and into the digestive tract where they belong. Think of saliva as a slow, steady river that keeps the riverbank from being colonized. Stop the river and the bank gets taken over quickly. The tongue coating is what colonization looks like at the surface. The significance extends beyond the mouth because the mouth and gut are the two ends of the same tube. Oral candida does not stay at the top. Research published in the Journal of Oral Microbiology documented significant correlation between oral candida colonization and gut candida overgrowth. consistent with the concept that microbial populations migrate down the digestive tract from the oral cavity. A persistent white tongue coating is not just a local oral hygiene issue. It may be the visible tip of a system-wide microbial imbalance that affects digestion, immune function, and inflammatory load throughout the GI tract. Sign number 3. Where a white coating points toward microbial imbalance, a yellow coating, particularly a thick, sticky yellowish-brown layer concentrated toward the back and center of the tongue, points toward the digestive system, specifically the upper GI tract and the liver's bile handling capacity. Bile is a greenish-yellow fluid produced by the liver, stored in the gallbladder, and released into the small intestine in response to fat in a meal. Its job is to emulsify dietary fat, to break large fat droplets into smaller ones that digestive enzymes can work on. When digestion is working efficiently, bile flows in the right amount at the right times and the system moves. When gastric motility slows, meaning the muscular contractions that push food through the system become less frequent or less forceful, food sits longer in the upper GI tract than it should. Bacterial fermentation increases. Byproduct gases and heat build up in the digestive tissues, and markers of this sluggishness appear on the tongue. Traditional Chinese medicine identified this pattern empirically over 2,000 years ago, describing yellow tongue coating as a sign of stomach heat and digestive stagnation. Western medicine dismissed this as prescientific pattern matching, but a study published in Nature Communications in 2019 analyzed the tongue microbiome of patients with different metabolic and digestive conditions, including healthy controls, patients with non-alcoholic fatty liver disease, and patients with type 2 diabetes, and found statistically significant differences in tongue coating appearance, thickness, and color across these groups. The tongue was not just reflecting generic poor health, it was distinguishing between specific metabolic conditions at a level that aligned with known patterns in traditional diagnostic systems. After 55, the digestive slowdown is real. Gastric emptying rate decreases. Digestive enzyme secretion from the pancreas declines. Bile composition shifts toward higher cholesterol concentration, which increases the risk of cholesterol gallstone formation, and gallstones occur in approximately 15% of adults over 60, with most never producing acute symptoms until a complication develops. The system runs slower, and the tongue coating at the back reflects this. We have been told, and I caught myself in this for years, that digestive changes in your 50s and 60s are just normal aging. Slower metabolism, slower transit time, just how things are now. The American Gastroenterological Association has been consistent in its guidance that while modest physiological slowing is real, clinically significant changes in digestive function and bowel habit in adults over 50 should not be attributed to aging without investigation. Aging is not an explanation. Aging is a context. The actual cause is still findable if someone looks. That is the mainstream betrayal embedded in this. The phrase, "this is just part of getting older," has become a clinical default that ends the investigation. The tongue does not accept that answer. It keeps printing. Sign number 2. Look at the surface of your tongue itself, under any coating. Not at the edges, not at the color, at the actual structural surface. If you see cracks, grooves, or fissures running through the tongue tissue, some shallow, some deep enough to harbor debris, some running lengthwise down the center, some branching across the width, you are looking at what medicine calls fissured tongue, sometimes called scrotal tongue, when the pattern is particularly deep and branched. Fissured tongue affects an estimated 5% of the general adult population and becomes substantially more prevalent with age. Some estimates place its occurrence in up to 30% of elderly adults. The fissures themselves can be cosmetically minor or deep enough to trap food particles and bacteria, creating persistent bad breath that does not respond to normal brushing or rinsing because the source is lodged in tissue grooves that standard hygiene tools cannot adequately clean. But the biological mechanism behind fissuring is what makes it worth understanding. The tongue regenerates its surface cells rapidly. The papillae cycle through complete regeneration approximately every 10 to 14 days, one of the fastest cellular turnover rates in the body. To sustain this regeneration, the tongue requires continuous adequate supply of vitamin B2, riboflavin, vitamin B3, niacin, vitamin B6, pyridoxine, iron, and sufficient hydration at the cellular level. When this supply is compromised, the surface tissue cannot regenerate properly. It dries, it contracts, it splits. Think of clay that dries too quickly. When the surface layer contracts faster than the interior can support, it cracks. The fissuring on the tongue is that same contraction, tissue trying to renew itself without the raw materials to do so smoothly. There is a dehydration dimension here that most adults over 55 systematically underestimate. The thirst mechanism, the body's internal signal that triggers the conscious desire to drink, becomes less sensitive with age. Research published in the Journal of Gerontology documented that older adults show significantly blunted thirst responses to fluid deprivation compared to younger adults, even when plasma osmolality, the concentration of solutes in the blood, rises to levels that would produce intense thirst in a 25-year-old. The result is that many older adults are chronically mildly dehydrated without feeling particularly thirsty, and the tongue surface is one of the earliest tissues to show that cellular water deficit through cracking and fissuring. At the more specific end of the diagnostic spectrum, fissured tongue is a recognized feature of Sjogren's syndrome, an autoimmune condition in which the immune system attacks moisture-producing glands, causing chronic dryness in the mouth, eyes, and other mucous membranes. Sjogren's affects an estimated 4 million Americans, with approximately 90% of diagnoses occurring in women. The average time from symptom onset to accurate diagnosis is approximately 2.8 years. 2.8 years during which symptoms of dry mouth, dry eyes, fatigue, and joint stiffness are frequently attributed to menopause, stress, anxiety, or aging in general. The tongue fissuring that accompanies Sjogren's is one of the early visible signs. It goes unrecognized almost universally in primary care, not because doctors do not know about Sjogren's, but because the tongue is not being examined with diagnostic intent. The connection between the sign in the mirror and the condition in the chart never gets made. If your tongue has visible fissuring, and you also experience chronic dry mouth, dry eyes, unexplained fatigue, or morning joint stiffness that takes more than 30 minutes to improve, that specific cluster warrants mentioning to your doctor as a pattern, not as vague complaints, but as a clinically recognized triad. An ANA panel and anti-SSA and anti-SSB antibody tests are the standard screen. You are allowed to name those tests in the conversation. Here is where I want to pause for a moment. I had read all of this. I had the studies bookmarked, the mechanisms understood, the patterns mapped out in my head, and for a long time it just sat there, theoretically useful and practically inert. Knowing what to look for and having a daily structure that makes doing something about it almost effortless are genuinely different things, and I confused them for longer than I should have. My husband had pieced the daily structure together well before I finally used it. He had been through his own near disaster, an aortic aneurysm, and severely elevated cholesterol. 8 years ago, the kind of event that ends with a lifetime stack of prescriptions and the clear message that the system did not catch it early. He spent the next 2 years reading everything: circadian biology, metabolic timing, the Nobel Prize research on how the body's internal clock governs cell repair, immune function, and nutrient processing. And then he built something daily out of it, because reading the research and actually changing what you do every morning are separated by a gap that structure closes. The guide is called the Noon Reset Protocol. It runs 30 days, broken into 4 phases: adaptation, activation, optimization, and acceleration. Because the first 4 days feel completely different from day 15, and knowing that in advance is the difference between continuing and quitting. It is a 2-page daily structure. 1 page of the science rationale for that phase, 1 page of tracker. It includes 25 breakfast meal ideas with exact protein counts, which sounds minor until you realize how many people undermine the entire morning window by eating the wrong thing at the wrong time after it. He made it available to others through the link in the description for less than the cost of a restaurant meal. I took an embarrassingly long time to actually use what was sitting on the kitchen counter. I am choosing not to calculate how much time exactly. Now, sign number 1. Look at your tongue again. Not at the coating, not at the edges. Look at the texture of the actual tissue surface. A healthy tongue has a faintly rough, velvety appearance, the accumulated surface of thousands of small papillae creating a nap like the surface of a fabric. If your tongue instead looks smooth, flat, and almost shiny, if the texture appears to have been polished away, leaving a glassy or glass-like surface, you are looking at what clinicians call atrophic glossitis, and it is the most consequential sign on this entire list. Atrophic glossitis is the condition in which the filiform papillae, the fine hair-like projections that form the tongue's normal velvety texture, atrophy and disappear. They do not regrow spontaneously once the underlying deficiency goes uncorrected. The tongue retains that smooth, bald-looking surface. It is often accompanied by unusual paleness, a lighter pink or even almost white color rather than the healthy pink-red of a well-perfused tongue. Some people experience a burning sensation, unusual tenderness, or a persistent metallic taste. Many people experience no discomfort whatsoever and have no idea anything is wrong. Here is the mechanism. Specifically, the filiform papillae are among the most metabolically demanding structures in the oral cavity. They regenerate on a rapid cycle of approximately 10 to 14 days, which means they require a constant, uninterrupted supply of three specific nutrients to complete that cycle: vitamin B12, iron, and folate. When any one of these falls below the threshold needed to sustain rapid cell division, the papillae cannot complete regeneration. They atrophy. They fall away. The tongue becomes smooth, but the papillae are not the clinically important part of this story. They are just the visible indicator. The tissues that share the same metabolic demand, the same absolute dependence on B12, iron, and folate for their rapid cell turnover, are the tissues with the highest stakes: red blood cells, which complete their own rapid production cycle in the bone marrow, the mucosa of the gut lining, and most critically, the myelin sheath, the insulating layer that wraps around nerve fibers throughout the brain and spinal cord and peripheral nervous system, allowing electrical signals to travel accurately and at the correct speed. When B12 is functionally deficient over time, myelin begins to degrade. The condition this produces in the spinal cord is called subacute combined degeneration, a progressive demyelination that affects the posterior and lateral columns and produces a characteristic clinical picture: first tingling or numbness in the hands and feet, then balance disturbances, then cognitive changes, then, if the process continues uncorrected, irreversible neurological damage. The early symptoms, the tingling, the mild balance issues, the slight mental fog that feels like it might just be tiredness, are so nonspecific that they are almost universally attributed to aging, poor sleep, or stress until the neurological examination finds something that cannot be attributed to aging anymore. The Framingham Heart Study, tracking residents of Framingham, Massachusetts since 1948, and one of the most rigorously conducted longitudinal health studies in history, found that nearly 40% of participants across a wide age range had B12 levels in the low normal range, with the oldest participants showing the highest rates of functional deficiency. Separately, a study in the American Journal of Clinical Nutrition found that food-bound B12 malabsorption, specifically the failure to extract B12 from the protein structures in animal food, affects between 10 and 30% of adults over 50. Here is the piece that makes this genuinely alarming and genuinely actionable at the same time. The standard blood test ordered to check B12 status, serum B12, is a notoriously imprecise diagnostic tool. It measures total B12 in the blood, including inactive and analog forms that do not contribute to cellular function. A result in the low normal range, say between 100 and 300 picograms per milliliter, which is technically within the reference range at most laboratories, can mask a genuine functional deficiency that is actively affecting your tissues. The test says adequate. The body is running short. Two more sensitive markers exist. Methylmalonic acid rises in the blood and urine when B12 is functionally insufficient at the cellular level because a B12-dependent enzyme is needed to clear it. Homocysteine similarly rises when B12 and folate are both functionally low. Neither of these tests is part of a standard metabolic panel. They require a specific clinical order, and they are rarely ordered unless the doctor already suspects a deficiency, which they often do not, because the serum B12 came back technically normal. The National Institutes of Health made a specific recommendation that adults over 50 obtain their B12 from fortified foods or crystalline supplements rather than relying exclusively on food sources. The reason is precisely this. Crystalline B12, the synthetic form in supplements and fortified foods, bypasses the food-bound absorption pathway that requires intact stomach acid and intrinsic factor. It can be absorbed by a passive diffusion mechanism that remains partially functional even when intrinsic factor production is reduced. This recommendation exists. It is published. It is not routinely communicated to patients. A smooth tongue after 55 is the body's earliest externally visible signal that this system may have failed. It is preceded by months or years of internal deficit that left no external sign until the papillae could no longer regenerate. If you are looking at a smooth, pale tongue right now, especially if you are also experiencing any tingling in the extremities, unusual fatigue, or cognitive changes that feel different from normal tiredness, the specific ask for your doctor is methylmalonic acid and homocysteine levels, not serum B12 alone. That is the clinically sensitive screen. You are entitled to name it specifically. The 3-surface read, 30 seconds every morning before food and before coffee. Coffee alters the pH and stimulates salivary flow in ways that can partially strip the coating before you have read it. The coating your tongue prints overnight is the one that contains the information. Do the check first. Surface 1, the coating layer. Look at what sits on top of your tongue. A normal, healthy coating is a thin, barely visible pale white film, almost translucent. If you see thick white texture, especially toward the back and center, that points toward microbial imbalance, oral candida activity, likely driven by dry mouth, medication side effects, or immune changes. If you see a yellow-brown layer concentrated at the back, that points toward digestive sluggishness, bile dynamics, and upper GI function. If you see no coating at all, if the tongue surface looks bare and wet and almost glassy, that is its own signal, which brings you to the next surface. Surface 2, the structural layer underneath the coating. Wipe your tongue lightly with a clean finger or a tissue to clear the coating if it is thick, and look at the tissue itself. You are looking for 3 things. Texture first. Is it velvety and slightly rough, or smooth and flat and shiny? A smooth, polished surface is atrophic glossitis until proven otherwise after 55. Color second, healthy pink-red or pale and blanched. Pallor can indicate anemia from iron deficiency, from B12 deficiency, or from both simultaneously, and it appears in the tongue before it appears in the face reliably. Fissures and cracks third. Are they present? How deep? How widespread? Then look at the lateral edges for scalloping. Each of these structural features points to a different system, and together they give you a more complete picture than any one sign alone. Surface 3, the movement check. Stick your tongue straight out and hold it still for 5 seconds. You are looking for 2 things. Deviation. Does the tongue pull noticeably to one side rather than extending straight forward? Deviation can be an early neurological sign, particularly relevant in the context of stroke risk in adults over 55, and it warrants immediate clinical investigation. Fasciculation second. Do you see small, rapid twitches or tremors in the tongue tissue while it is extended? Fasciculation in the tongue can indicate motor neuron involvement, thyroid dysfunction, or, most commonly in this population, functional B12 or magnesium deficiency affecting nerve signaling. This check takes 5 seconds. It has a legitimate history in clinical neurological examination. The most common mistake people make is doing this check after their morning coffee or after brushing. The overnight coating is the data. Everything after that is a partially erased printout. Do the read first, every single morning, before you introduce anything into the system. 3 surfaces. 30 seconds. You cannot unsee what you learn to look for. And what you see gives you something specific and informed to bring into a medical conversation, instead of a vague sense that something feels off. The tongue has been telling us things for a very long time. We built entire diagnostic traditions around it: Chinese medicine, Ayurvedic practice, 19th century Western clinical examination all included it as primary data. Then imaging and blood panels arrived, and we stopped looking at the one organ available for free in any bathroom mirror. It is one of the more understandable shortcuts medicine has taken. It is also one of the more consequential ones. You cannot have a silent absorption failure happening in your stomach, and a quietly demyelinating nervous system, and a visible signal on your tongue every morning, and then decide the signal is not worth 30 seconds. If you looked at your tongue this morning and found at least one sign from this list, comment Tion Dig check below so I can see who is actually paying attention. Then subscribe, because this is what I do. I read the boring clinical stuff and tell you what is actually in it.